Welcome, everyone. I'm Dr. Carmen Puliafito, and I'm happy to welcome back to Retina Synthesis Dr. Robert Avery of California Retina Consultants. Bob, welcome back.
Thanks, Carmen. It's great to be back.
You've been an authority of gene therapy for neovascular AMD. And of course, as we know, there are three delivery routes: intravitreal, suprachoroidal, and subretinal. And it's an interesting picture that's developing. You presented a very interesting paper at the American Society of Retina Specialists meeting discussing the results of a phase 2 pharmacodynamic study of subretinal gene therapy. What's pharmacodynamics?
Well, it looks at the effects, not just the pharmacokinetics, the level of the molecules there, but also the effect on the actual disease process. For instance, we looked at the treatment burden reduction, in addition to the PK, the typical PK measuring the level of anti-VEGF agent, ranibizumab-like agent that was produced at 6 months. That was actually the primary endpoint,
Mhm.
comparing this new sort of bioreactor method of production of the gene agent versus a hyperstack method, which was used in the smaller clinical trials previously. You need to be able to scale up production of these gene agents if you're going to go commercial. And that's what they were testing, this newer, higher volume production method to see if the gene product worked the same. And so
So,
that was tested and
so
it
how
did.
many eyes in the study?
Well, I had four different groups with 15 eyes each, so it was 60 eyes. And it did mimic what was seen in the phase 1/2 study, but in a way, it answers more than just one question. It answers that yes, the new bioreactor method is comparable in gene, the production of the gene therapy in the way of the anti-VEGF antibody that's produced. And it also confirmed a lot of the results of the phase, 1/2 study, but with some minor modifications that will be carried forth into the phase 3 study, which are an improvement upon the phase 1/2 from what we learned in the phase 1/2 study.
What about treatment burden reduction?
Well, we had definite treatment burden reduction. These were previously treated patients, on average 6 or 7 treatments annualized over a year. And the reduction was over 50%. And there were two different groups, so two different dosing groups, which were sort of in the happy medium, the sweet spot in the 5 cohorts in the phase 1/2 study. This is between cohort 4 and 5, basically, and 3 and 5, where the sweet spot was. And these two doses both had about the same treatment reduction burden. Ironically, the lower dose had a slightly higher one. But in the higher dose, it was over 50% of people needed no additional treatment during the 1 year. And in the lower dose, it was closer to 60%. And those receiving only one injection were about 75% in the lower dose cohort and about 2/3 in the higher dose cohort. So a big reduction in treatment burden relative to the previous, you know, pre-treatment era or period for those patients.
So, were ranibizumab levels measured in this study?
They were. That was the primary endpoint at 6 months, and they were comparable between the two doses and also between the two methods of production of the gene therapy, and both felt to be therapeutic levels. And so it does seem to they're around 500 nanograms per mil. So it's pretty comparable between the high and the low dose, and also between the two different mechanisms of production. So that was the
So,
primary point.
this was vitreous sampling?
This is more aqueous sampling. The vitreous sampling, as you know, is sort of hard to do
Yes.
in patients. It's great in animals, but we have to rely on the vitreous samples a lot more now for people in clinical trials, as you know. So.
Hmm. So, where is the ranibizumab produced?
Well, the gene itself transfects in the subretinal space. It really transfects the retinal cells and also the RPE, and it does seem to be produced in that area. We know from the different mechanisms you mentioned before, the intravitreal injections seem to also transduce in the iris and the ciliary epithelium and places in addition to the retina. And so that may have some effect on the, hypotony complications seen with one previous agent. But the subretinal space is harder to access, obviously, but it is more immunoprivileged and it also localizes the production a bit better, I think, than the intravitreal mechanism of
So what
administration.
are, what dose are they using in the phase 3 trial?
Well, they're the same two doses that we used here, and as I said, they're intermediate between the phase 3 and 5. It's like 10e, uh, 3 times 10e to the 11th, and it's in that range. It's something that I think they really have tried to find the happy medium. We had more sort of pigmentary side effects with the highest dose, but we had higher VEGF levels in the cohort 5 in the phase 1 study, and 1/2 study. And this sort of, I think, is the sort of the sweet spot. And we had a good clinical response in this trial with both of these doses. And so I do think that this is probably likely to be the right dose frame for trying to get the right get the right dosing here.
How far along is the phase 3 trial?
They're enrolling. They've been enrolling for some time. I can't tell you the exact status of it, but it is progressing, and it is something that I think will be, uh, very exciting to see the results of. Because it does seem to, having been a top enroller in phase 1, 2, does seem to be a great effect when the patients really
Mhm.
realize the
Mhm.
reduction in their treatment burden. And I think one advance of this phase 3, and was also shown here in this phase 2 study we just presented, is we changed the location of the administration of the drug to get rid of one of the major side effects seen in the phase 1 study, and that is the pigmentary changes. These were
Right.
fairly common in the phase 2 study, but they were all peripheral, and we've started doing the injections outside and inferior to the inferior arcade so that any of the IP doesn't seem to affect the macular pigment. And so we keep those pigment changes peripheral. And, worst case, imagine doing a sector PRP in a patient to allow them not to need any further treatment. I mean, we've done that in diabetes for years. And so even if you get significant, very peripheral pigmentary changes, I think it's a small trade-off in order to allow for, a great reduction in the treatment burden. Where we had problems was where the drug passed through the fovea, and we had some central pigment atrophy later on in that phase 1. But that's obliterated. None of that was seen. No central pigment modeling or change was seen in these 60 patients.
That's wonderful. Um, what's your perspective on the intravitreal and suprachoroidal delivery routes? What are your thoughts?
I'm very intrigued by all of them, or both of them, I should say. The intravitreal obviously had some issues with the high dose it was used, where we had hypotony in some cohort of diabetics. I think that my personal feeling is that that may have been potential over transduction of the ciliary epithelium or something of that sort that may have helped produce a lot of aflibercept-like molecule, but may have prevented the aqueous production. I have not really seen that in print, but I could foresee that being one mechanism by which you just sort of hijack certain cells to produce the drug, and they may not make some of the other things that are necessary for ocular health. And so that company, Adverum, has really lowered the dose significantly, and their phase 2 results are very impressive. How they have obliterated that sort of side effect. They don't have any hypotony. The inflammation, which was always a little bit of concern at the end of the trial, everyone was off steroids, and it looks to be a much safer dose that they're using now. the actual protein production is less. And so I doubt we'll have the same number of one and dones, but safety is paramount. You have to have a safe agent to make it into clinical practice. And picking a safer dose, I think, was a good idea. They clearly are showing a reduction in treatment burden as well. It's interesting how similar all of these agents, including 4-DMT, is also showing a similar reduction in treatment burden with their agent, which is also given intravitreally. Again, the protein production isn't quite as high as we saw initially with the cohort 5 and the Regenexbio or the early optic study from Adverum, but they're seeing an effect on the treatment burden, and they did measure protein. Both of those companies have measured, all three of the companies have measured protein in the aqueous, but to a lesser degree than we saw initially. So I think we're sort of, again, trying to find that medium, that sweet spot where we can have treatment effect without the side effects. Because we have a good treatment now. It's a pain for the patient due to treatment burden, but we don't want to sacrifice safety. We don't want to, have a severe hypotony case or something we can't even treat, much less, in particular, when we could have a safer treatment. So I think they're all in the right direction. They're all going in the right direction. All the companies are coming up with something to reduce the treatment burden. And it'll be interesting to compare it to like the TKIs, where you're seeing a similar
Yes.
a reduction in treatment burden, but with every 6 months or 9 months or yearly injection. And this could be a quite similar effect with one injection or one procedure to lower the treatment burden. I'm not saying they're all five going to be the same, but it's interesting how similar they're appearing in the treatment burden reduction right now. So it's going to be very fun to see how this all plays out.
What
Um,
about suprachoroidal?
Suprachoroidal is also moving in the right direction. I mean, they have a treatment reduction burden as well. And, there have been good animal studies showing that you get a similar sort of transduction. My gut feeling is it's not quite as potent as subretinal, but obviously it's a lot easier than subretinal in the patient. And for diseases such as diabetes, where you don't want to do a vitrectomy because most of those patients, younger patients, may be phakic, and you will induce a cataract, and it's just much more invasive for disease, especially diabetic retinopathy instead of diabetic macular edema, where it's an asymptomatic disease. I mean, the ability to give a single shot and try to prevent diabetic retinopathy progression is very appealing, and it's a huge market. It hasn't been taken up. It's not practiced. It's not very widely used in practice, even though the anti-VEGFs are on label for diabetic retinopathy reduction. It's the treatment burden is too high relative to the amount of effort involved about relative to the benefit to patients who are asymptomatic. They would rather wait till something happens and then deal with it. But I think these either intravitreal or suprachoroidal injections, a one-time shot that really reduces your diabetic retinopathy progression risk is very viable, and I'm excited to see that. And the suprachoroidal may be a very good avenue for that.
Well, Regenexbio is covering at least two of the bases,
Yes, they are. They are.
and they're doing it in both diabetic retinopathy and neovascular AMD.
Yes, they're
Suprachoroidal.
suprachoroidal for diabetes. My personal gut feeling is it probably didn't produce enough anti-VEGF to treat AMD, but I that's personal feeling. I don't know.
Yes.
That's not been
Yeah.
proven, but I think the fact that they're moving forward in diabetes sort of is one reason I think that's probably the case.
Last
Because
question.
we'd
What's
all rather be able to do intravitreal or
right?
suprachoroidal than have take someone to the operating room.
Yeah. Final question. What's the horizon here? What is if successful, we're seeing 5 years from now in the
Uh,
marketplace or less?
Oh, I certainly hope it's sooner than that. I think they're still in the throes of the phase 3 studies with Regenex, and but surgical trials take longer, and so it is something that um, you know eh, you never know when you're gonna. I don't know when they're gonna finish, But I think once they get that, and if these new changes we made in the phase 2 hold up, I think that, without the major side effects we talked about with the pigment change in the macula, I think it has a strong shot at being approved. It is more invasive, but man, I certainly hope we have that in our armamentarium in less than 5 years. I think it'll be
Yeah.
sooner than that.
Is the study endpoint at 1 year or longer?
Well, I think that the FDA wants them to follow it for longer. I mean, that's the nature. I mean, even though you could get an effect by then, um, and safety being with gene therapy, safety is even more of concern. And so
Hmm.
I don't think you can get approval for gene therapy in 1 year. But the FDA is in such a state of flux right now. I don't even know what to think because what I think is probably wrong. But things are changing very rapidly at the FDA, and so this could be good or bad for the chances of approval in a short period of time.
Well, Bob, thanks a lot for your insights about gene therapy for retinal disease. And we are waiting for the results.
Carmen, it's a pleasure to speak here on your podcast. Thank you so much.